Hello everybody, welcome to number 1 Doctor channel. Today we will talk about incisions of anterior abdominal wall principles. There are 3 requirements for a proper abdominal incision: accessibility, extensibility, viability. A surgeon must plan the incision, taking personal preferences into account. The following rules should be observed where they apply. The incision should be long enough for a good exposure and for room to work, but short enough to avoid unnecessary complications. Where possible, skin incisions should follow Langer's lines. Excise existing scars and proceed, rather than making incisions parallel to the scars. Split muscles in the direction of their fibers, rather than transecting them. The rectus muscle is an exception, because it has a segmental nerve supply and therefore no risk of denervation. Do not superimpose the openings formed through different layers of the abdominal wall. Wherever possible, avoid cutting nerves. Retract muscles and abdominal organs toward, not away from, their neurovascular supply. Insert drainage tubes in separate small incisions. Insertion in the main incision may weaken the wound. Pay close attention to cosmetic considerations, but not at the expense of the requirements of accessibility, extensibility, and viability, as noted previously. Be sure closure follows anatomical topography. Viability dictates using care in patients with multiple abdominal incisions. New incisions must be placed such that skin necrosis is avoided. Surgical anatomy of specific incisions. Upper midline incision. Incisions of the linea alba and the transversalis fascia may reveal abundant and well-vascularized fat in the upper midline. We suggest that the incisions of the peritoneum be made slightly to the left of the midline to avoid the ligamentum teres in the edge of the falciform ligament. If it is encountered, it may be ligated and divided. Close the linea alba from above downward. Alternatively, closing from caudal to cranial may be easier and cause less evisceration as you approach the costal margin. A thoracic extension of a midline abdominal incision may be made through the 8th intercostal space as far as the scapula. In this procedure, the midline incision is exploratory, and the need for the thoracic extension depends on the pathology revealed by the exploration. Sternal splitting may be used to continue the midline incision superiorly. A lateral extension to one or even both sides may be L or T-shaped. A downward continuation of an upper midline incision is always an available option. Lower midline incision. There are some anatomical differences in the midline above and below the umbilicus. The linea alba is narrow and more difficult to identify below. Remember that the bladder must always be decompressed. An upward extension of a lower midline incision is always available to the surgeon. The incision should go around the umbilicus to the left to avoid the ligamentum teres and an unclean umbilicus. Lateral extensions are the same as those of upper midline extensions. Occasionally the anatomy of the umbilicus permits a transumbilical extension. The surgeon must be sure the umbilical folds are clean. Rectus paramedian incision. This incision is preferred by the surgeon who wishes to close the abdominal wall in layers. It does not destroy muscle tissue or nerves. Retract the rectus muscle laterally to prevent tension on vessels and nerves. Feasible extensions may be made as described for midline incisions. Rectus incision. The incision is made along the lateral border of the rectus sheath. This is an undesirable incision because it cuts across the nerve supply to the rectus muscle. The blood supply from the inferior epigastric artery also may be compromised. Extensions will further injure nerves and blood vessels. Transverse incisions. In this type of incision, both rectus sheath and muscle are cut. All the transverse incisions may be extended in the midline. Upper abdomen rectus muscle and the flat muscles may be cut in the line of the skin incision. Lower abdomen phalansteal incision. This incision is made horizontally just above the pubis. The anterior rectus sheaths and the linea alba are transected and reflected upward 10 cm. The rectus muscles are retracted laterally, and the transversalis fascia and the peritoneum may be cut in the midline. The iliohypogastric nerve must be identified and protected. The lower abdominal incision may be extended laterally by dividing the tendinous attachment of the rectus muscle to the pubis. Lateral extension also may be attained by leaving the rectus muscle attached, but retracting it medially and splitting the muscles of the anterolateral wall. This usually requires ligation of the inferior epigastric vessels. Extension too far laterally may jeopardize the iliohypogastric and ilioinguinal nerves. Oblique incisions. An oblique incision can be extended laterally to the contralateral side of the body or to the same side by following the costal arch and avoiding the nerves. It may be extended upward or downward on the linea alba. It may be extended obliquely upward through the costal arch if it is necessary to convert it to a thoraco-abdominal incision. Subcostal incision. The rectus sheath is incised transversely. The rectus muscle is cut and the external oblique muscle is split and retracted. The incision should extend laterally no further than necessary in order to avoid cutting intercostal nerves. The operator usually sees the small 8th and the larger 9th nerves. The latter should be retracted and preserved. The external oblique, internal oblique, and transversus abdominis muscles usually can be split. Occasionally, the external oblique fibers must be cut laterally and downward. A subcostal incision 2 finger breadths below and parallel to the right costal margin is the incision most frequently used. McBurney incision. The skin is incised for about 8 cm starting 4 cm medial to the right anterior superior iliac spine and extending downward on a line from the spine to the umbilicus. The aponeurosis of the external oblique and the internal oblique and transversus abdominis muscles are split in the direction of their fibers. The iliohypogastric nerve, deep to the internal oblique muscle, must be identified and preserved. McBurney incision may be extended upward and laterally for several centimeters without cutting muscles. Medial extension requires transecting the rectus sheath and muscle. In some instances, it is easier to close the incision and make a new one. Thoraco-abdominal incisions. Various incisions have been reported for exposure of lesions in the upper abdomen and lower thorax. Thoracic incisions have been made through intercostal spaces 5 to 9 or by resection of ribs 7 to 9. The abdominal portion of the incision has been either a midline or a transverse continuation of the thoracic incisions. It may or may not extend into the rectus abdominis. Use this incision only if it is absolutely necessary. Dehiscence of the incision. Obesity, prolonged ileus or bowel obstruction, and wound infection are important factors of dehiscence. Dehiscence is caused by poor quality of the tissue or suturing with bites that are too small, placed too far apart, or tied too tightly. Because wounds in patients with hypoproteinemia heal slowly, hyperalimentation is recommended for those whose protein intake is at all questionable. In contaminated cases, secondary closure of the skin 4-5 days later is a mature surgical decision. The sutures at the initial closure may be placed, but not tied until later. Good hemostasis, debridement, irrigation, good approximation of skin, absence of tension, and avoidance of dead spaces all contribute to good healing without wound dehiscence, postoperative incisional hernia, or a disfiguring scar. Thanks for watching. Please do not forget to like and share our video. Watch other videos in the channel. Subscribe to our channel. Numeron Doctor with my best wishes. Dr. Atef Ahmed. Best wishes.